record. Okay.
Good evening, everybody. Welcome to the Cell Science Systems webinar, monthly webinar. We'll begin in just a few seconds. We're having a little technical issue with getting the recorded version started. Dr. Ron, I think you have to give her permission to record.
No, I did.
It's recording.
Thank you. All right, well, it's 7 o'clock straight up. We appreciate everybody taking time out of their day to attend this informative webinar. If you've been on any of our webinars before, you know Dr. Grabowski does a great job of giving you some clinical pearls to take home, take to see your patients tomorrow. And I want to just give you a little background quickly on Dr. Grabowski in case you don't know who he is. Dr. Ron Grabowski is a practicing doctor of chiropractic in Houston, Texas. He has over 40 years of clinical nutrition experience, presented over 1,500 seminars and lectures on nutrition throughout the United States and in Europe. He's published several articles and a textbook on clinical nutrition. He's also a registered dietitian, and his dietetic experience includes tenure at some of the leading hospitals in the nation. The New York Hospital, Memorial Sloan Kettering in New York City, affiliated with Cornell Medical Center, Memorial Care System, and University of Texas MD Anderson Cancer Center in Houston, Texas. His research interests include nutritional support of the athlete and the use of supplements in clinical practice for the prevention and management of chronic disease such as diabetes, heart disease, autoimmune, musculoskeletal conditions, and gastrointestinal disorders. We appreciate everybody coming here tonight. Just a little housekeeping. We'd like you to, if you have questions, of course, put them in the Q&A section of your Zoom. That's on the bottom of your toolbar there. We'll get to those at the very end. And also, you'll find this copy of the slide deck in the chat room. Don't put the questions in the chat room, but that's where you can find the copy of the slides. And of course, if you've attending here live, anybody who is registered will get automatically, whether they attend live or not, will get a recorded copy of this webinar. But without any further ado, we'd like to welcome Dr. Grabowski and turn it over to him.
Thanks, Robert, and good evening, everybody. As you know, every week we see patients, several of our patients come in and talk about how they're depressed or they suffer with anxiety. And since COVID hit in 2020, we know that these numbers have increased substantially. And you can see here in the International Society of Nutritional Psychiatry Research, they definitely recognize that there's a big importance of the intervention of nutrition with this particular subject. And so several of our patients, as you know, come in and they're on medications for depression or anxiety. And one, they either want to decrease the dosage because they have some side effects with those medications, and or they want to maybe get off those medications if they can. And so it's very important that we understand that this is a very in-depth subject when it comes to nutritional intervention, because you'll see by the end of tonight how many nutrients have been associated with this more or less condition or conditions. You can see a lot of people suffer every year with this particular condition. In fact, they say 1 out of 10 people in the United States are on antidepressant or anti-anxiety medication, which is very concerning if you think about it, especially when some research says that only about 30 to 35% of people get full benefit from it, and the other 65% only get partial benefit. So we know that nutrition is extremely important in this, but we also know that exercise comes into play. And I'll talk a little bit about that as far as intervening exercise or physical activity with that and some of the statistics that show the benefit of both. As you can see here, there is a higher prevalence of major depressive disorder with females than males. And then of course you can see the age group that has substantial evidence of having this problem, the 18 to 25-year-old. And once again, we now know that with COVID hitting us in 2020, that even younger individuals now are getting involved. And it'd be interesting to see the statistics that come out in the next few years on how many people that suffer with anxiety or depression are in the younger age group besides, of course, under 18. And of course, there is some ethnicity associated with this condition as well. So as I mentioned, one of the things that, of course, we should promote besides nutrition or in addition to nutrition is exercise. Of course, we know that exercise is very important for helping mental health, but at the same time, if you over exercise, which a lot of people do, of course, they come home, they're stressed out and they say, I'm going to go to the gym and work out for 2 or 3 hours and try to relieve my stress. Well, we're going to talk about that and how does that really impact us, and does it get us into trouble with certain nutrients and cause the situation that we're trying to actually resolve. And you'll see that it definitely does that. So it's very, very important. Of course, when we talk about anxiety or depression, of course, we have to talk about the neurotransmitters. And this is just a few that we're going to talk about today in regards to their involvement with the production of serotonin, dopamine, or norepinephrine. As you know, the medications that are prescribed out there are usually the SSRIs, the selective serotonin reuptake inhibitors, or the SNRIs, of course, the serotonin norepinephrine reuptake inhibitors. So as you know, just what they say, they inhibit the uptake or the reuptake of those particular neurotransmitters. But my question to you is, and you should also think of this and tell your patients this, is what happens if you don't make those? What happens if you don't make serotonin? What happens if you don't make norepinephrine? What happens if you don't make dopamine? Those medications aren't going to work because they work on preventing the reuptake of those particular neurotransmitters. And that's what's really important. It's kind of like saying, I have the car, but I don't have the gas to drive my car. Well, of course, it's nice that you have a nice car, but you don't have the gas, or vice versa. So we have to really consider that when we are looking at supporting these individuals with nutritional supplementation. And that's why when we see certain nutrients that are low on testing, we can correlate that, okay, this one makes serotonin, or this one makes dopamine, or norepinephrine, or whatever, as it states here in this particular slide. There's a lot of etiologies of depression that come into play. As you can see, this is a list of them, and we're going to talk about several of these tonight. From a genetic standpoint, major depressive disorder, MDD, which you'll hear me talk about more this evening. Some say only 35% is hereditary, and yet I hear that all the time from my patients that come and they go, oh yeah, my doctor says that my depression is hereditary because one of my family members has it. Well, it may be, but on the other hand, it may not be. It may be that more than one of you have different nutritional deficiencies that are related to the neurotransmitters, or there's some other factors in life that come into play, like stress, which we'll talk about quite a bit, because this is a huge subject. In fact, two of my new patients today, they told me at the very beginning of the consult, I'm here today and I have these diseases because of stress. And then once again, one of the two was on an anti-anxiety medication. And of course, they were put on the anti-anxiety medication after they started having this one condition. So the point is that stress has a big impact on us, and we all have stress. And once again, we're going to talk about that more today and how that really comes into play. So as we know, one of the stress hormones is cortisol. And there's a lot of evidence out there that cortisol causes depression. And once again, you can see here that it really causes a hyperactivity of the HPA axis. And we hear that all the time. And of course, there's some evidence that there might be some glucocorticoid resistance involved, and that may also be a reason why cortisol has a bigger impact. We also know that circulating cortisol levels can lead to reduction of neurogenesis, which of course is another factor. We're going to talk about its enrollment with inflammatory markers as well, and how they come into play, and how inflammation, it plays a big role with anxiety and depression. And a lot of people, once again, relate other diseases today to chronic inflammation. So it's something we definitely have to keep in mind. So talking about inflammation and depression, you can see that once again, when we have inflammatory process going on, we have what we call inflammatory cytokines that are released, and you start to see changes in serotonin levels, the glutamate metabolism, it says here, the dopamine pathways, as well as the HPA axis, and then of course the microglia activation. Of course, When we talk about the nerve cell, the brain cells, of course, we have to think about chronic situations. If we have chronic inflammation, is it going to lead us to dementia / Alzheimer's down the road? And of course, the overall structure or integrity of the nerve cells when we are looking at these particular factors, which is huge. And once again, that's why you see people out there writing books on the anti-inflammatory diet, or they're looking at foods that they have an intolerance to that are causing general inflammation. Or why does a person that exercise heavily go into depression? You know, are they developing what we call leaky gut syndrome and things like that that are causing an inflammatory marker? Well, what's interesting is they have actually monitored, of course, some of these common inflammatory markers like C-reactive protein, interleukin-6, and interleukin-1, and so on. And you can see that they have seen a correlation with major depressive disorder. And so once again, when you are looking at an individual that has anxiety or depression, are you looking at these markers? Are you measuring the CRP? And if you do see a CRP that's elevated, you say, oh yeah, the CRP is elevated, and that means you're more prone to cardiovascular disease or stroke. Well, yes, that's true, but it's also where your mental health is correlated to that as well. And there's several nutrients that actually, of course, lower CRP, other than the classic ones that people think about as far as like omega-3s or vitamin C and something like that. We're going to talk about various other nutrients that actually affect these inflammatory markers, and you will see how many of these nutrients actually come into play. I think if I took a poll from all of you this evening before I even started this webinar and said, what nutrients would you correlate or consider when you have a patient that has anxiety or depression? Of course, most of you would come into this arena right here. You'd say, oh, yeah, B vitamins, or specifically B12 or folate. And of course, we've heard all this about the methylation pathway, which of course is essential to our health. And that's true that a lot of people do have B12 and folate deficiencies, but I think I'm going to surprise a lot of you tonight with some of the nutrients that actually play a huge role with these two subjects as far as depression and anxiety. And of course, my question also to you is, if you have a person that has anxiety or depression, are you measuring their homocysteine levels? Because once again, homocysteine has a huge impact, as we know with vascular, it has a huge impact with brain integrity. And so these are findings that we look at. And of course, as you can see here, on the very bottom at excessive homocysteine, how it has an effect, a neurotoxic effect, which again activates the melatonin receptors. And once again, and this is associated with depression. So very, very important that we look at this as far as from the methylation pathway, and there's other nutrients besides just B12 and folate that, of course, in there. So here's a schematic that came out. You can see in 2020, I think does a good job in relationship to associating B12 and depression. And you can see there's different mechanisms, different correlations here as far as the serotonin system, the dopamine system, the adrenergic system, of course, the glutaminergic system as well. So it's a multi-system affected by one particular nutrient. And if you think about this, and I see this all the time, and I've seen this through the years, where people come in and they say, oh yeah, you know, I've had GERD for several years, and I've been on Nexium, or I've been on Prilosec or Prevacid, and I don't know what it is, but I'm fatigued now, and I feel like maybe I'm even depressed. And of course, what happens is they go to their regular doctor and they do some testing, and they might do a serum B12, which isn't very accurate, but they do it anyways. It comes back normal and say, oh no, it's not nutrition related because your B12 is normal. But once again, it's only one nutrient, and I'm going to show you multiple nutrients that have a role in this particular subject. So, but the point is, some of those medications like that, like the proton pump inhibitors or H2 histamine blocking agents, definitely predispose us to a vitamin B12 deficiency, and once again sets us up. But I think a lot of people don't correlate that when they come in. They go, oh yeah, you have GERD. Okay, well, let's not talk about that. You're fatigued. So if you're fatigued, yeah, you're depressed, and let's get you on antidepressant. Here's, once again, another schematic from the same article showing you the B12 deficiency, the elevation of homocysteine, how homocysteine, of course, hits the mitochondria, of course, causes oxidative stress, and it goes down through the schematic. And the end result is depression. And once again, so when we are talking about this particular subject, and hopefully by the end of this evening, you see that is you go, boom, I need to start monitoring homocysteine levels, not just for heart disease or stroke, but I also have to do it for this particular subject as well. And if you listen to my webinar the last 2 months on osteoporosis, we also talked about homocysteine and osteoporosis. So homocysteine has a huge impact on multiple conditions, and I think it's really underutilized or underordered by a lot of people, and it needs to be ordered more frequently. Vitamin D, of course, we've heard this for a long time. People that are in certain states or certain countries where they don't have a lot of sunlight, like say in Alaska, where during the winter time, of course, there's very little sunlight for several months, of course, and they have what they call seasonal depression. Well, why might that be? Well, this is one of the reasons why is they may not be producing enough vitamin D because of lack of UV light getting into them. So we know that vitamin D is one of the nutrients that should always be considered with depression and or anxiety. And the thing is, people may be taking vitamin D, but the point is, do they have a vitamin D receptor SNP maybe that's being affected? So maybe that 5,000 for that one patient that helped them with their depression, 5,000 for another patient won't necessarily help them. And this is why we need to, once again, test these patients to see if they are utilizing the dosage and the quantity and the, the nutrients that are more or less related to this particular vitamin, like magnesium, which we'll talk about this evening as well. You can see some of the benefits of vitamin D in the brain are as listed here. The neuroplasticity, which is very important, which a lot of people hear about when they read specific articles on neuroanatomy and neurophysiology and things like that. But a lot of times people just really talk about the neurotransmitters and they don't talk about the cell membrane or the cell integrity, but they want to talk more about the neurotransmitters, which is important. But once again, this is just as important as well. And I think that's something that you all have to keep in mind. We'll talk about that more when we get into some other nutrients that really play a role with the cell membrane integrity. As I mentioned, don't just assume that a dosage that you're giving an individual of vitamin D is going to do it. You might say, oh yeah, well, you're a 16-year-old individual, you're almost adult, I think 4,000 IUs might be good enough, or maybe you're 35, 45-year-old patient, say, yeah, 5,000, 6,000 might be enough. Well, how do you know that? 3,000 might be enough. We don't know unless we do some objective testing. The same thing is we might have to get up to 10,000, 15,000, depending on, once again, their makeup. And once again, we have to have some objective data to say, yes, it is getting in the cell, it's doing its job. And once again, as you can see here, that vitamin D receptors are found in various areas and once again, have a huge impact in this subject. And when we talk about vitamin D, we always have to talk about things like magnesium and vitamin K2 and so on. So some of the actions that actually vitamin D has, as you can see here, the neurotrophin stimulation, of course, we all know that it has antioxidant qualities. The anti-inflammatory effect, which is very important, which I'm going to talk about more here in a little bit. And of course, we look at the glutathione metabolism. As we all know, we talk about glutathione and the master antioxidants high in the brain to protect the neurons from, of course, degeneration. And of course, you see some evidence out there today where people that have higher incidence of, or people that have depression have maybe higher incidence of dementia and or may have higher incidence of Alzheimer's. And it makes a lot of sense because if you have this chronic inflammatory process going on and you're damaging, of course, the brain cells because of this inflammation, maybe it is because of vitamin D deficiency, then once again, you may get dementia and or Alzheimer's. According to a lot of literature out there, some people say as high as 90% of the world population has an insufficient amount of vitamin D. And that's just one particular, of course, nutrient. If you talk about vitamin D, you have to talk about magnesium because, as you know, vitamin D helps enhance the uptake of magnesium from the GI tract. And then magnesium helps with the conversion of vitamin D as it's going through its various steps from hydroxylation from the skin to the liver to the kidneys. And you can see here that magnesium, when it's deficient, it actually leads to this overactivity of the NMD receptors. And once again, this causes further problems. And a lot of people don't necessarily realize this, but magnesium is an anti-inflammatory product. And when we are low in magnesium, we get an increased production of inflammatory cytokines. Now, I'm going to talk about this right now, but in depth in a little bit. But when we are under stress, we increase the loss of magnesium, primarily through the urine. And so this is why a lot of people that when they're under stress, they start to get muscle spasms, they start to get twitching of their eyelid or their face, they start to get, soreness of their muscles. And it's a lot of it can be due to a magnesium deficiency. If you're looking at serum magnesium, you're not going to pick it up because it's a very poor test, but yet people continue to do it. And so we look at it. So you can see here in regards to magnesium and the more or less the neurological change of the brains. And of course, we also know with the transmission of the glutamatergic transmission, I should say, has a big impact with magnesium or relationship with this. Now, this is something else to consider if you ever are utilizing things like glutamine, and they have some great it has some great benefits, which I'll talk about in future webinars. But is if a person has magnesium deficiency, they actually can have more side effects with that. For example, if a person has migraine headaches and you give them glutamine and they have a magnesium deficiency, they can actually have a neuroexcitatory reaction to that and actually make their migraines worse. So magnesium is very, very important for this transmission or this balance of certain nutrients, and we have to always keep that in mind. And that's why, once again, it's important that we determine that on some type of testing. So when we look at these channels, of course, one of the concerns or one of the relationships we look at is, of course, this calcium and sodium relationship with magnesium. We also, of course, look with potassium. As they say in nutritional classes or journals, that where magnesium goes, potassium follows. Well, we also know that calcium and sodium have some sort of relationship, and there's a balance of that. And when we have that imbalance between these particular nutrients, then of course we start to have problems develop. And this is why we have this overreactivity of some of these channels that occur. And of course, the same thing is true in, say, in cardiovascular. If we have a vitamin K2 deficiency, we can have more problems with calcium as far as the plaquing and things like that. Well, same thing is true with magnesium, and calcium and sodium comes into play. As I mentioned, cortisol is one of the issues that's been implicated out there with depression. Of course, we know that if it continues to be high, and of course, what happens or what causes that to be high is stress. And this is why we see people that are under constant stress that have these elevated cortisol levels, and then they start to have memory loss, they start to have anxiety, they start to have depression, they start to have diabetes and various other things. And long term, it can cause, of course, cell death in the body in various areas. Well, one of the things that's involved with that whole relationship is, of course, is adrenocorticotropin hormone that more or less modulates this process. And once again, magnesium has a relationship with that. So when we talk about the hyperactivity of the HPA axis, one of the things that can help that is magnesium. So, I hear this all the time from my patients. Well, doc, everybody has stress. And I go, you're right. But how you handle that stress, how your body reacts to that stress is highly dependent upon your nutritional status. If you are low in magnesium, you aren't able to modulate that HPA activity. And so then you're going to have more problems with the cortisol, and the cortisol is going to have more involvement with the inflammatory process or inflammatory cytokines, and it just ball and goes rolling down the hill and keeps getting bigger and bigger. And then people say, well, now where do I go? Now they go on antidepressants or anti-anxiety medications and so on. Instead of going backwards and say, okay, this is what the situation is. I need to make sure I have good nutritional status to handle that. So it's very, very important. Well, as you know, there's a lot of research out there today on what we call the gut-brain axis. What happens to the gut, or what the status of the gut is, can affect several things. It can affect the joint, it can affect the heart, it can affect the brain, and so on. Well, magnesium plays a role with maintaining our microbiome. And a lot of people don't necessarily realize this. There's other nutrients like vitamin D has a role, and B2 and B5 and so on. So if you have poor magnesium status, you may not be able to have an adequate or optimal microbiome. So it's not just say, oh yeah, I'm going to take a probiotic and solve the problem. Well, that sounds good, but once again, it may not be the thing that's going to correct everything. And as you can see here by the second bullet, that magnesium also has a relationship with modulating or controlling or lowering, if you want to say, these inflammatory markers. And so it's very, very important that we keep this in mind. So when we talked about vitamin D doing this, two, we've talked about magnesium doing this. We talked about the relationship of homocysteine inflammatory markers. So I think you can get the idea here that inflammation is a major player, but there's several nutrients that play a role in keeping that inflammation down and modulating these particular markers. So when people have depression, and it may be due to magnesium deficiency, this is really the things that we look at. We look at dysregulation of the HPA axis, which causes an increase in calcium in the brain, which of course causes increased inflammatory response. So that's more or less the proposed mechanisms or connections that we see with magnesium deficiency and depression. In regards to the antidepressant effects, you can see here that the magnesium more or less has an effect by the serotonergic effect, the noradrenergic, and dopamine as well. And so all three of those neurotransmitters are affected. We also have an impact on what we call the BD and F, or the brain-derived neurotropic factor. Now, this particular factor is very important to us from a neurological standpoint. One, it supports differentiation of the cells. Two, it affects maturation, the survival of the neurons. It also slows down the damage of the cell, so it has a neuroprotective effect. It also has an effect on glucose regulation and energy production. So if we can enhance this particular factor, it has multiple benefits. And one of the things that does that is magnesium. And once again, it's a very simple nutrient. It's one that's affected by a lot of things we do during our life. And once again, if you drink alcohol, you can enhance the loss of it. If you drink a lot of or consume caffeine products, if you consume a lot of refined carbohydrates, same thing. If you don't consume a lot of fruits and vegetables and nuts and seeds, this is also a nutrient that can be, of course, decreased in consumption. And of course, one of the things that we often see is it helps us sleep. I mean, there's several patients, and you probably have the same thing. Several patients say, oh yeah, I take some magnesium before I go to bed at night because it helps me sleep. And you're right, it does. And it helps with, you can see here, the biosynthesis of melatonin. So it has several benefits when it comes to anxiety, depression, of course, glucose regulation, the BDNF, and so on. There's a clinical trial that was done where they actually gave, you can see 248 milligrams of magnesium per day for 6 weeks, and it resulted in a significant benefit of these individuals based on this questionnaire. And you can see when you have a probability of better than 0.05, of course, it's substantial. And so we know that, once again, and during this trial, that it was very, very beneficial. And if you think about 248 milligrams of magnesium is not very much. Most, if you look at the RDA for adults, it's between 350 and 400. So this isn't even the RDA level of magnesium, and yet it showed some benefit to these particular individuals. How about anxiety? Well, magnesium has also been shown to help with anxiety. And you can see here, once again, in a study, they gave magnesium taurate or glycinate. Of course, glycinate is one of the highest bioavailabilities out there at a small dose. Once again, they gave anywhere between 125 and 300 milligrams at each meal and bedtime. And once again, they had some benefit as far as anxiety. So sometimes it doesn't take a large dose, but once again, we also have to realize, okay, if you're looking at magnesium, you have to look at vitamin D and what's their vitamin D status. And maybe they would have had even better results if they would have had a correlation there between knowing what the magnesium is of that individual along with the vitamin D. Here's a little outline per se, or kind of a block of some pathologies associated with zinc deficiency. And of course, I'm not talking about the Alzheimer's, cardiovascular, Wilson's disease today, but we are talking about depression. And you can see that once again, they have found lower serum zinc levels in depressed patients, and we'll talk about that in a second. They've also seen lower zinc intake in these individuals. And then also, of course, in animal studies, they've put them on zinc deficient diets, and of course, which has shown to induce depressive-like behavior. So we definitely know that zinc has a role with depression. And once again, so just in a short period of time, we talked about B12, we talked about folate, magnesium, vitamin D, and now zinc. So one of the things that zinc has really received more and more information on, or attention and research, is what we call the neuroplasticity, and that's noted in the second bullet. But of course, the synaptic transmission of the neurotransmitters, this has also been affected with zinc, and so this is very important. What's also important to think about is zinc is more commonly deficient in vegetarians. If you're a vegan, I know you say, well, I can get it from nuts and seeds, and I can get it from various grains and so on. The bioavailability of zinc from those products is very, very low, about 10 to 15%. So from versus the bioavailability of zinc from animal products, you're looking at about anywhere from 50 to 60, maybe 65%. So you have about a 6-fold better bioavailability of zinc from animal tissue, or I should say from animal products. And I'm not trying to push you vegans away from that and go into consuming animal products. I'm just saying that if you want that type of dietary lifestyle, you also have to realize that you're more prone to that deficiency of one of the nutrients like zinc. And so then you need to supplement, but more importantly, you need to, once again, test to see if that's something that you are deficient in. We also know that zinc has an impact on inflammation, as it states here, that we actually know that zinc supplementation has decreased CRP levels. And once again, this is something that I think all of us need to be, aware of, that we shouldn't just look at it from a cardiovascular stroke type of standpoint from that aspect. We also know that it prevents against lipid peroxidation, of course, the breakdown of the cell membrane and how that once again occurs. And we know that that's very important with the inflammatory process. Here's a nice schematic from the Journal of Frontier Pharmacology in 2017, showing kind of the relationship of decreased zinc levels and how it increases cortisol, and how inflammation can cause decreased zinc. And you can see this like kind of the dog chasing his tail type of situation. And you can see how we once again talked about the NMDA receptors. And if you increase those, of course, then you're going to have more problems with anxiety or depression. The other thing I want you to realize is that if you have a zinc deficiency, that you have more difficulty shutting off that HPA axis or modulating that HPA axis. So that's why you get the increased cortisol levels. And as you get that increased cortisol levels, then of course, we talked about the various functions that cortisol has and the relationship it has with depression, primarily through the inflammatory process. As I mentioned, this receptor, the N-methyl D-aspartate or NMD receptor, comes into play along with the nitric oxide synthase involvement. And this comes into play with, once again, depression. And we try to modulate this system, once again, through various nutrients, whether it's magnesium, whether it's zinc, and so on. So I want you to keep that in mind. And how often that comes up in these slides in regards to the importance of this receptor and modulating it through various nutrients. It's not just zinc, it's not just magnesium, but it's a combination. So this is a schematic from the same journal showing you that if you have decreased zinc levels, how you get the activation of MNDA receptor, and then of course it goes into this particular area and it causes problems with, of course, depression or inflammation, and then glutamatergic neurotransmission comes into play. And then of course you involve your calcium. Once again, you increase your calcium release and it starts this whole ball rolling, as we talked about it earlier. As I mentioned early on, stress, and you can see here that if you have a zinc deficiency, you have plasma zinc levels go down, you have an increase in your HPA axis activity. When you have that, you have the glucocorticoids come into play, and then you have this all excited toxicity that goes in effect, and stress accelerates this. And so once again, we all have the stress in our life. But what's our nutritional status when we're confronted by that stress? And if it's a chronic stress, we have a daily stress or weekly stress or monthly stress, are we nutritionally adequate to handle that particular mode? And it's not just zinc, but once again, it's magnesium, it's vitamin D, it's some of the B vitamins and so on. And so this is, once again, kind of a summary of zinc deficiency and what happens and some of the things that are associated with the neurological system and why we actually get into trouble when we have this deficiency. And it's a lot more common than you realize out there. A lot of people I know do serum zinc testing. It's not very accurate. That's not my belief. That's what the literature says. It doesn't tell us long-term evaluation of zinc. It just tells us a very short-term process, the last few days, what's going on. We want to look at the long term. It's like looking at serum glucose versus HbA1c. We know HbA1c gives us a long-term evaluation. Serum glucose just gives us a short-term. Same thing with serum zinc or serum B12 or serum magnesium. They're very short-term when we're looking at the status of those nutrients. So as far as the development of depression, what happens is if you have a zinc deficiency, that's when you get the increased cortisol, you get, of course, the decrease in neurogenesis, you also affect the neuroplasticity, like I mentioned earlier, and of course, then the glutamate homeostasis and the inflammatory process gets out of hand. The antidepressive effects of zinc is when you supplement zinc, then of course, the NMDA it works as an antagonist to that. It, of course, elevates the expression of the hippocampal and cortical brain-derived neurotrophic factor. And once again, that has multiple benefits, as I mentioned earlier. Selenium. One thing I think is really interesting, if you look at the literature with selenium, or the relationship of selenium and what it does for the body, most people say, oh, selenium, thyroid. And if you think about it, one of the things that happens when a person's thyroid function is not optimal, one of the systems that gets affected is the brain. People that have hypothyroidism often say, I have more brain fog, I don't have the memory I used to, but once they get their thyroid under control, whether it's through nutrition or medication, those things change. We also know it affects the GI tract, it also affects cardiovascular, it also affects skeletal system. So if you think about that, selenium is a major player with the thyroid. And selenium has been found to modulate several things, the dopamine, the serotonin, the noradrenergic systems, and so on. And so this is why, once again, selenium has to be considered when we have individuals that have mental health disorders like depression. We also, once again, as I mentioned, selenium has a relationship with the dopamine neurons. And once again, if you have this inflammation or oxidative stress, which of course selenium, as you know, has antioxidant qualities, it will help prevent this from happening. And of course, long term, it helps prevent neurodegeneration. So once again, very, very important. Not as commonly found in foods as we think. Of course, people think about Brazil nuts or various other products, but the question is, just because you eat Brazil nuts, are you getting enough selenium out of that? Don't just assume, oh yeah, consume 3 to 5 Brazil nuts a day and you'll get your selenium content. Well, That's what some of the food chemistry journals say, yet you get so much selenium in Brazil nuts. But once again, has soils changed? Of course they have. Has transportation affected our food? Absolutely. So we can't just assume that by telling someone to consume a food that they're going to get adequate selenium and take care of it. So from a developmental point of depression, selenium deficiency, once again, has an effect on the thyroid and has effect on oxidative stress and of course, overall inflammatory pathways. And we talked about how inflammation affects, once again, our body and sets us up for depression and anxiety. As an antidepressant action, if we supplement with selenium, these are the benefits. We affect the serotonin, the dopamine, the noradrenaline modulation, and once again, overall inflammation. Omega-3s, I think this is one of the more common things. I think, like I said, if I would have asked you things at the very beginning, what are some nutrients or products that you would recommend to people that have anxiety or depression, you would have probably said the B12 and the folate, like I mentioned, things in the methylation pathway. But you probably also would have said omega-3s. And you're right, they definitely have a benefit. As you can see here, it's been listed for several years on the benefit of this particular product. So once again, are we taking in enough? You know, a lot of people out there don't eat a lot of fish. They don't consume these things on a regular basis from a supplemental standpoint, but this is definitely one thing that should be looked at. And you can see here that in this Australian study, they definitely found that given the DHA helped with anxiety. And then below that, of course, about 50% reduction in anxiety disorders with these individuals. And then the study here in the United Kingdom, they gave 1.5 grams per week of long chain, once again, fatty acids. And they saw a decrease in anxiety in the pregnant women. So we know that there's definitely a relationship with anxiety and depression. It has to do with the neuroplasticity and also the anti-inflammatory effect. We all know that omega-3s have anti-inflammatory effects. This is probably one of the nutrients that I utilize the most in my practice for anxiety and depression, and I see deficient the most in blood testing. And what's interesting when reading into the literature with this is how this nutrient, this amino acid is very important, but by combining it with the omega-3s, you get an even additional benefit. And so once again, the dosage for the most part that I've seen being beneficial, and you'll see in some of the statements here, I see the dosage between 200 and 800 milligrams a day. And I always split that up as I go. I'll give 200 or 300 at one time, but I'll never give more than 300 milligrams at one time. So if I have to give 600 or 800, I'll usually split it. If it's 600, you should do 300 twice a day or 400 twice a day, but it definitely has some benefits. And one of the benefits is how it affects the lipid layer of the cell membrane. And that's what's really important. We're talking about kind of the neuroplasticity. And you can see here in some clinical studies, they've actually reported significant benefits between 200 and 600 milligrams per day at as short as 30 days, which is pretty interesting because a lot of times we don't see a lot of benefits from nutritional intervention until about 2 or 3 months. So to see it in 30 days is pretty good. And then there's another study here. You can see they combine the phosphatidylserine with some DHA and EPA. And once again, they had some significant improvement after 12 weeks. So once again, combining certain nutrients or finding certain nutrients deficient at the same time. So if you did some testing, you saw they were low in serine and they were also low in omega-3s, combining those two, you can sometimes get a double benefits, just like combining magnesium and vitamin D. These are some of the mechanisms they talk about and why phosphatidylserine may actually help. You can see it may affect the ACTH. Of course, that's once again talking about the cortisol release, of course, reducing the cortisol levels, and also possibly modulating the whole HPA axis. So when people say, oh, I'm stressed out, and even maybe before you test them, you might say, they might want to leave your office and you're waiting for some test results, say, hey, look, I want to put you on this. I want to put you on a low dose like this, maybe get, that into them for 2 or 3 weeks before you get the results from your lab test. And once again, they may see some benefit. Once again, it may take 30 days, may take a little longer, but the point is, we definitely know it has some benefit. One that is not as commonly talked about out there, but is in the literature, as you can see, the L-acetylcarnitine. Once again, this is a very interesting nutrient, and you can see giving you information here how it may once again benefit in regards to the depression. Alpha lipoic acid, most of the time when we talk about alpha lipoic acid, we talk about diabetes, we talk about non-alcohol fatty liver disease, and that's why once again we have this insulin resistance relationship. But look at here, once again, we have a nutrient helping another nutrient. That alpha lipoic acid, if you get it with acetyl-L-carnitine, then once again, it may be a double benefit. It also may affect the BDNF that we talked about earlier that has substantial benefits to the neurological center and has so many different mechanisms that we think that the BDNF is involved with. So the alpha lipoic acid, once again, is very important. Most of the literature, when you talk about alpha lipoic acid, like I said, it talks about insulin resistance or diabetes. They usually will say somewhere between 400 and 1600 milligrams a day. So I know that's a large range, but most of the time we will see benefit at 400 to 800 milligrams. So you don't necessarily have to go to 1600. When people talk about CoQ10, most of the time they think about cardiovascular or they think about the brain, because we know that CoQ10 deficiency has been associated with possibly Parkinson's and Alzheimer's, but you can see here that it has been associated with bipolar, it's been associated with multiple sclerosis and some various other things. So we don't want to just limit our CoQ10 to, once again, a cardiovascular system, but once again, we know that it does have a benefit to the central nervous system and something we want to monitor. Now think about this. People out there taking statin medications, which we know affect CoQ10 synthesis in the body. How many of those people say, God, you know what, I'm just getting depressed the older I get. Like when I hit 50 or I hit 60 or 70, man, I feel more depressed. I'm not motivated for anything. And they might have been on statin for 10, 15, 20 years. Have you ever related that depression or that lack of motivation to CoQ10 deficiency? Maybe not. So here, once again, hopefully this opens your eyes to that fact. And here's some studies. They've actually shown that in major depressive disorder that they've seen lower levels of CoQ10 levels. And so once again, same thing with bipolar. So we have to keep all that in mind when we're looking, and that's why I'm saying that this depression anxiety is not a simple, oh, it's a B complex problem or it's an amino acid problem. It's a lot more involved. And once again, inositol. I remember when I was doing my training 40 some years ago that we used to use inositol in the psychiatric ward all the time for anxiety, for insomnia and things like that. We used to have significant benefits back then. And I think it's kind of fallen between the cracks, but some of you that have been in this field for a while know that, you know, inositol is very beneficial. It has great benefits for PCOS, has, you know, other benefits for, like I said, sugar control, glucose control, and so once again, it also can be used for anxiety or depression. Iron, we don't want to forget about iron because once again, iron has a significant impact with our central nervous system. As you can see here, it affects the dopamine. And once again, if you suspect this, some of the testing that you can do is transferrin, of course, ferritin levels. So if a person has a borderline ferritin level, like, you know, some labs range like 15 to 150. If they're running a 20 or 25 ferritin, yeah, it's within normal range, but is that optimal for them? Is that enough to say, yes, that could be a cause of your anxiety or depression? We talk about tryptophan. Of course, tryptophan's been used for sleep. Well, we know that also has a relationship with serotonin, and these are some of the things we look at. People use it to, you know, manipulate their cravings for carbohydrates and things like that. And these are just a little schematic that has been shown there as well. And then here's a couple other amino acids, lysine and arginine. Now, when we think about lysine, of course, a lot of times we think antiviral. When we think about arginine, of course, arginine has a huge impact with the immune system as well. We also see arginine deficiency occurring in athletes. We use it for healing, like if people have connective tissue injuries, we see that. But once again, you can see when they combine lysine and arginine together, that they actually saw some benefit with anxiety. So when you test and you see some of these particular nutrients being low, once again, you can see that correlation. So here we have a slide of kind of highlighting the nutrients that we talked about um, tonight and how they're correlated. You can see they're vast. So you have a lot to consider when you are looking at a person who has depression or anxiety. It's not just one of these, but it could be a combination. Like I said, looking at the serine, and we didn't highlight that, we should have highlighted that. But the serine below there, right below lysine, that's something that we look at very closely as well. So, and then the CoQ10, of course, lipoic acid, selenium. So here's a couple of case studies of these are actual patients of mine, and showing you these individuals. And once again, this is a female that suffers with depression. And you can see things that kind of showed up here. We have the zinc deficiency that was significantly low. Then of course the lipoic acid there, that's low. We have the K1 that's once again affected, but some of these others, we have the B9 or the folate that's involved. So this is one individual that has multiple nutrient deficiencies that are correlated with what we talked about tonight. And so it's not just, oh yeah, I'm going to correct that zinc and that may help. And this is why when people just say, oh yeah, I've got on the internet, I heard zinc's good for depression, they take it. Well, if you're not low in zinc, additional zinc isn't going to help you. But if you're low in it, it's going to be significant benefit. And that's the big thing that we have to really emphasize to our, once again, to our patients. And then if you look at the APA on the right hand here, what's really interesting is if you go to the bottom of that particular page, you see that lipoic acid is protective of this person from an antioxidant, anti-inflammatory effect. So they have a significant deficiency of lipoic acid in the CMA. And now that it's confirmed that that particular product has an anti-inflammatory and antioxidant effect for them. So definitely you would want to supplement this person with lipoic acid. Here's an individual, it's actually a male individual that has a high problem with anxiety, very long-term situations, been an anti-anxiety, antidepressants. It's actually a professional individual, has a high-stress job, very good at what he does. But you can see there's multiple things here that we're looking at. This one has a B12. He also has a zinc problem. He has a lysine that's borderline. So once again, some similar things that the other person had, the female patient had, but some things that weren't there. This person doesn't have a folate problem. This person doesn't have a lipoic acid problem. This person doesn't have a CoQ10 problem. One reason why he doesn't have a CoQ10 problem is because he was on a statin several years ago and he's been taking CoQ10 for numerous years. So that's one of the reasons. But the point is that this is why we can't just cookie cut these people and say, okay, take, zinc or take B12 or take folate, or let's just shotgun you and take a multivitamin out of this. Because once again, one, are you getting the right dosage? And two, are you getting the right product? And so hopefully this shows you by these two cases that we have to really treat everybody individually. And once again, it has to be an aspect, a point of one, we need some objective data to say this is what you need, and then retest the individual to say, yes, we've corrected that particular individual. Okay. All right. So now we're up for, Q&A session. And once again, there's some information here that we want to provide to you in regards to scheduling some consults with Cell Science or Previmedica. And Robert, I'll open it up for questions.
Thank you so much, Dr. Grabowski. That was an excellent presentation as usual. And we do have a few questions. Before we get to the questions, we want to remind people, these are where you can find more information out. Dr. Grabowski mentioned about Cell Science Systems. In our testing, we offer SICA, which is a celiac, IBS, and Crohn's array. The CNA, which is what was focused tonight, our micronutrient test, antioxidant test. We do telomere, we do methyl detox, and we also have our flagship test since the late 80s, our ALCAT test. That's our food sensitivity test. And just to give you a little heads up, sometime it looks like in June, we're going to have a deep dive on the difference between ALCAT and IgG testing. And that's going to be performed by Amy, our head nutritionist and dietitian at Previmedica, and our CEO. Roger Deutsch. He's going to be, those two are going to be performing this. So stay tuned for that. And just to give you another little commercial, Dr. Grabowski next Wednesday on 3/29 at 2 p.m. in the afternoon for RUPA. Those are you familiar with RUPA? He's going to be covering the topic importance of functional laboratory diagnostics. So he'll be delving deeper into the CNA test that we offer here at Cell Science Systems. And if you want to reach out to any of us here, you see our phone, my phone number, my email, and here's next month's April's webinar, micronutrients role in maintenance and repair of the GI tract. So I'm sure everyone will be interested in attending that, and look for your invitations for that in the email blast that we'll be sending out. So let's get to the questions. We have a few questions here. Here's one. Any concern regarding supplementation of zinc in competition with copper absorption? What time frame, duration for supplementation would be safe, effective?
As long as you keep the zinc at a lower level, a lower amount, like if you give 20 milligrams or less, you can give copper with it, but you always want to try to keep about a 10-to-1 ratio of zinc to copper. And you can do it. It's when we get into these large dosages of some of our, especially our minerals, like our divalent cations, like calcium, magnesium, zinc, copper, iron, and so on, that really inhibits the other mineral. But if you give it in small amounts, and this is why I'm really a big advocate about multiple dosing throughout the day. They've even seen this with water-soluble nutrients like vitamin C and B12 and so on, that if you give high dosages, that you can interfere with other nutrients. And hopefully in the near future, I'll be giving a webinar on nutrient-nutrient interactions, as well as nutrient-drug interactions, how certain nutrients inhibit other nutrients, and why it's important that we multi-dose our patients. Because I know a lot of people say, wow, I can't remember that afternoon dose, but I can remember that morning dose, so I just take everything in the morning. Well, that's fine, but you're going to really inhibit that. So as long as you look at a ratio, keep the ratio about a 10-to-1, it's really when you get above 15-to-1 zinc to copper that you really start to have problems.
Okay, great. Will magnesium 3 and 8 help with bowel movements or just the brain?
It will help. I mean, magnesium as a whole of any form will help somewhat with that. It's primarily for the brain, and that's why people use it. Magnesium citrate is the best form, really, if you want to affect the bowel. But once again, you look at bioavailability, but it will have some benefit. It's not going to be substantial like the magnesium citrate.
And in line with that, I'm sure this has to do with the discussion tonight. Which type of magnesium are you recommending?
Well, magnesium glycinate is great for bioavailability and uptake of magnesium if you're trying to correct a magnesium deficiency. If you are looking at a neurotransmitter or effect on the central nervous system, magnesium 3 and 8 is a better choice. But once again, it's also comes into play with, what's the neuroplasticity of the cell? I mean, do we have good omega-3s? Do we have good omega-9s and so on that are affecting these nutrients getting into the cell or affecting the integrity of the cell?
Okay, another magnesium question. How much magnesium is safe?
Well, once again, that's all individual, but I mean, the dosages that you can definitely consider, you can see some where as low as like 240, 250 that saw some benefit. You can go as high as 800 to 1,000 milligrams a day. But once again, the point is this. What else can you cause from that? If you go too high with magnesium, you can cause a calcium imbalance. You can cause a B1 or thiamine deficiency. So this is when we, once again, in the future, when we can talk about a nutrient interaction webinar or nutrient drug interaction, is there's a balance there. And so some people may need more. I mean, there's people who have autoimmune diseases, for example, that need, 15,000 IUs of vitamin D a day, and it doesn't cause any problems. Now, on the average individual, you get that much vitamin D, you may cause some major problems. So it depends what's going on. It depends upon the biochemistry. It also depends upon if they have any SNPs that are involved. That's where the methylation detox comes into play, and looking at magnesium and that. So there's a lot of variables, but usually if you stay somewhere between 300 and 600, it's a very safe range.
Okay, and if there is a plus VDR defect, is the treatment adjustment of the vitamin D dose?
Yes, usually you increase the dosage of vitamin D. That's correct. But I think there's still a lot of research that has to be done on these receptors, and maybe we find out that there's other complementary nutrients that will help with those receptors and so on. But usually that's what we do, or that's what most people do, is they increase a dose to kind of override that VDR SNP.
Okay, and K2 in regards to D.
There's not really, well, there's a relationship, but those two complement each other from several aspects, from vascular to skeletal and so on. But there's not really a ratio that we look at. Usually when we look at vitamin K2, the dosage, we look somewhere between about 180 to 300 micrograms. But if you're talking about ratio or anything, there's not really ratio, because there's different measurements. I mean, we look at micrograms, or we look at international units with vitamin D versus micrograms with vitamin K2, but they're very complementary to each other, but there's not really a ratio that we look at.
Okay, I'm gonna see if I can understand this question. I see more phosphatidylcholine and use serine to lower cortisol. I don't know if that's a question or a comment.
Yes, that can definitely, I mean, when we look at phosphatidylcholine, I mean, phosphatidylcholine also has an effect on the neuroplasticity. I mean, that's one of the things. That choline, as you know, is a phospholipid and it helps the cell membrane. Well, once again, the PS does the same thing, is that it can affect the membrane, but it can also modulate some other things that we talked about with the HPA axis and things like that. So sometimes you'll see combinations of that there's companies out there that actually combine the phosphatidylcholine, phosphatidylserine together, and I can see a benefit of that. But once again, there's ways of testing. As you can see with the CMA, we test the choline, we test the serine, so we can tell which one is maybe of demand, and most might be in demand.
Okay, here's another good question. What would be the significance of only one or two amino acids being low, like histidine, as it relates to histaminic patients?
Yes, absolutely. That's something it's interesting that you said that, because we were just talking about that this evening before we started the webinar, and how we're seeing some correlation that if people have food intolerances, or if they have something going on in their system that is causing an increase in histamine production, of course, histidine helps do that. So if you see something like histidine low on the CMA, that yes, you can more or less kind of determine that this person might have some histamine reaction going on, and now you have to determine what's causing it. Is it airborne? Is it food intolerance? What's causing that? That's causing that demand. And so by replacing histidine, it's yes, you're helping that deficiency, but the point is it's more or less telling you that there's some histaminic reaction going on, and you need to solve that.
Thank you. And what is dosage of CoQ10 per day? And I might add, what form?
Okay, well, ubiquinol is a preferred form. As we get older, we find that ubiquinone doesn't necessarily convert to ubiquinol as efficiently. This is just something I've seen clinically over the last several years, that if a person is a poor methylator, so if they've had an abnormal MTHFR, that they definitely need ubiquinol versus ubiquinone to correct their intracellular ubiquinol demand. The research has been anywhere, if we're talking adults now, not children, but if we're talking about adults, the dosage has gone anywhere from 100 to 1200 milligrams a day for certain conditions. Like in Parkinson's disease, they've actually given 1200 milligrams and shut down tremors on Parkinson's patients. The problem with that, and once again, this goes to nutrient interactions, is when you give large dosages of CoQ10, you have the possibility of depleting carnitine or pantothenic acid. It's a triad that I talk a lot about. Some of you that have consulted with me over testing, I've told you about that triad, and that's very important. So, more doesn't mean it's better. And so when people say, oh yeah, I'm taking a stand, I need this much. That's why, once again, you need testing. Okay, let's test you. If you're low in CoQ10, let's start out with a certain dose, maybe a conservative dose, retest you in 6 to 9 months. If you're corrected it, then that's good. If you didn't correct it, then that also tells you as a clinician, okay, I need to bump up the dose. And that's why we test. It's the whole point of it, is just don't assume, oh, I'm going to give 100, I'll give 300. I've seen people on 300 milligrams of CoQ10 and they're still deficient on the test. So once again, there's a lot of things involved that come into play. And I think it's very important that we all really look down at, objective testing.
Here's a comment I think maybe you could address. I have a 22-year-old daughter home from college, depressed in her senior year and lots of anxiety. Well, she's in college. Trying to help her heal now. What can you?
Well, this is the whole thing about stress. This is what I'm talking about, and, we've all gone through college and there's, sometimes your funds are limited, so you don't eat the best. And, you're sit there staying up at night from 12 to 3 o'clock in the morning, drinking 5 cups of coffee to get ready for a final exam or midterm, right? And things like that happen. Maybe you go out on weekends, you're drinking some alcohol, so you're causing some deficiencies like magnesium and some other water soluble products like B12 and things like that. I know you want the answer and I can't give a direct answer, but there's a lot of things, like I said, the stress. I mean, let's talk about zinc and let's talk about the B vitamins and let's talk about phosphatidylserine. Those are some things I would definitely look into right away, is get them on a B complex, possibly, look at magnesium medicine. Like I said, there's a large portion of people out there that are vitamin D deficient. So vitamin D has to be towards the top of the list. And I would start there, but definitely test her. Don't guess, don't try to play with her health. No one would want you to do that to you, or you wouldn't want anybody to do that with you. When you take your car to a mechanic, you don't say, okay, just throw in there whatever you need. Of course, they hook it up to the computer and they say, here, this is what's wrong with it. Well, that's why we have to do objective testing.
Okay, let's do this last one. Is there a problem with calcium, magnesium, more like 1 to 1 than say 2 to 1?
No, it's not at all. In fact, I often do that in my practice. There are a lot more things in life or in our dietary habits, our lifestyles, that affect magnesium than affect calcium. In fact, a lot of times I will do a 1 to 1 ratio of calcium to magnesium. In fact, even in cardiovascular literature, they've shown that when they've increased the magnesium to the calcium level, that they've lowered triglyceride levels, they've lowered cholesterol levels. So I'm a big magnesium fan, and I've said this before on webinars, and I say this to my patients. If I could only carry one nutrient in my office, it would be magnesium, because of the significant impact it has in so many systems, and several things that we do during the day affect it. Stress affects it. Bad diet affects it, sugar intake affects it, alcohol affects it, caffeine affects it. There's so many things that happens during everyday life that affects our magnesium. So yes, I'm a big proponent of going closer to a 1 to 1 ratio of calcium magnesium.
Well, great. That's all we have time for tonight. Thanks so much for everybody's good questions, and thank you for attending. We look forward to seeing you on next month's webinar. And Dr. Grabowski, we thank you very much. Thank you, Amy, for all your help. And everybody have a good night till the next time.
All right, good night.